So I wanted to clarify emerge directives, just to make sure everybody understands clearly what they are about and how to use them. So if you go to the intranet, they're here. You get a binder on the unit, but they're also on the intranet here under medical directives on the internet. So you're going to go there, and then you're going to select your medical directives folder and then emergency department, and that's where all your ED medical directives are. So you've got the 7 core directives. So within the 7 core directives, there's a bunch of things that people need to be aware of. So the first thing is that they're only valid on an 18-year-old or older. So it has to be an adult person. The other thing is, so in the actual medical directives policy that guides the use of these things, it clearly states that if you have not been trained to utilize the medical directives, then you are not supposed to trigger them. So if you are one of those people who has not yet been trained, you need to reach out to me so that we can get your training done for these medical directives and sign you off. The other really important thing is you want to make sure that when you're doing a directive that you're reading all of the criteria clearly to make sure that you're not triggering a directive that isn't appropriate for the patient. So the one thing here, so there are a bunch of different symptoms listed under each one of these sort of potential directives. And I'm thinking that people are sort of treating them like, oh, I'm just going to trigger the directive if one of these things applies. So we do need to use a little bit of clinical judgment, I think, on these things as well. Just because somebody is pale, for example, it doesn't mean that they have acute coronary syndromes. So you have to make sure that you sort of have met the baseline criteria. So manifested by discomfort, non-radiating anterior or posterior from jaw to umbilicus, that may include any of the following. So it may include, but it doesn't have to be those things. The abdo pain directive is probably one of the ones that has sort of created the most confusion. So acute non-traumatic abdominal pain. So by EC test rules, acute means anything within a month. For our purposes with this directive, I would suggest that you consider acute being something within a couple of days, so 48 to 72 hours. If it's been going on longer than that, then I wouldn't necessarily trigger this abdominal pain directive. I would let the physician see the patient and figure it out from there. The other thing is, if you know there's an obvious reason for it, if the patient states they're constipated and they're pretty clinically, they're describing a constipation, you got to ask yourself, do I need the blood work and all the components that are with this abdo pain directive along with that? And if the answer to that is no, you can choose not to select that abdo pain directive as well. So this is the big one. So history of sudden onset of severe pain. So sudden onset, obviously, and severe pain means 8, 9, 10. So somebody presenting with pain 6 or 7 out of 10 that's been sort of like gradually sort of getting worse over the last couple of days may not be the person that we want to trigger this directive on. Again, use your clinical judgment. If you think that the patient will benefit from the orders that are within that directive, then yeah, go trigger ahead. You're not getting in trouble for triggering it, but you're also not going to get in trouble for not triggering it. And then I think these parts here in this directive should have been indented. So may appear pale, ashen, diaphoretic, with nausea and vomiting, restless or dehydrated. So all these sort of should fall under the may appear. In the written version, we have indented those pieces, but when they show up on your screen, they're not necessarily. So don't treat each one of those symptoms like something you should trigger a directive with. Make sure that you meet those first 2 criteria, I think, at first. Just to make sure, again, clinical judgment is key here. If you think that the patient will benefit from the directive, then go ahead and trigger it. Otherwise, you can hold off. I think one of the reasons people are doing the abdominal pain is they're thinking they need a urine for a patient on abdominal pain. So there is actually a directive specifically for UTIs here. So if you're suspecting your patient has a UTI and you want to have a urine, you don't necessarily have to trigger the abdo pain directive. You can trigger the UTI directive, which will be more appropriate for the patient. So there's a couple of things in here. So, you've got an extremity weakness directive, which is for like your CVA patients. Again, if we're going to do stroke protocol on these patients, then we don't necessarily want to trigger these directives because we're getting them out the door. The other one, so in the imaging directives, if we go to the imaging directives, so if you go to the imaging directives, they're basically broken down by body part later in the directive here. So if you've got a foot x-ray, so these are the indications for your foot x-ray. So these are all under the core directives. An ankle x-ray, then these are the things that you meet. The ankle one, so if you look at Appendix 3, there's the Ottawa ankle rules, which is down here. So the Ottawa ankle rules and the Ottawa knee rules. I'm going to laminate and post these so that they're available in triage, so that we have them as a resource for you. But so x-rays are basically broken down into specific body parts on the core imaging directive. So just keep that in mind whenever you're looking at an injury. Take a look at these to make sure that you are meeting the criteria for an x-ray. And that you're not missing anything. And then if you look, there's all kinds of ED specific ones. The ones that I think are probably the most relevant to us right off the bat. So the extremity injury obviously is going to be something where you can have analgesia and x-rays. You still want to be able to meet those criteria from that core to trigger the x-rays. Your chest pain directive obviously is going to be one that we're going to use fairly often. Abdo pain as well, we're going to use fairly often. Fever, I think we can use probably fairly often. The pain, mild to moderate, so this is Tylenol or ibuprofen. To clarify, if a patient has had Tylenol and is still having pain, it is appropriate to give them ibuprofen. Nausea, vomiting is one as well that we're probably going to use fairly often. The flank pain directive. So this flank pain directive is actually intended for your renal colic patients. If you suspect that your patient has a renal colic, this is the guy that you're going to want to trigger this flank pain on. It doesn't really apply to other situations as well. There might be some, but I think this is more your renal colic patients that you're considering for this flank pain. And then I think that pretty much is everything I wanted to kind of talk about with these directives. Once the physician has seen the patient, you can no longer trigger a medical directive. So if the physician tells you, yeah, well, trigger the medical directive for chest pain, that is no longer a medical directive, that is a verbal order. So when you enter it in the system, you can still enter it in the system, enter it as a verbal order, because it's no longer a medical directive at that point. It was driven by the physician. And yeah, make sure you read those criteria. And if you haven't been trained yet, please reach out to me because you do need the training to use these directives. That's it.